All right. Good morning, everybody. Welcome to all my listeners. This is episode 12 in season 12. Today is Wednesday, July 24th, 2024. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. Now, all right, you guys, today's another big day where my Newsworthy is going to be featuring my Spotlight series. That's right. I'm going to be bringing back Keisha Wilson. We heard from her a month or two ago, right, on her journey. But today I wanted to welcome her back warmly so she could shine her spotlight on her expertise. And then, of course, our entire conversation is going to be peppered with all of our trusty tips and recommendations based on her expertise. Now, today's episode is sponsored by Advanced Coding Services. Advanced Coding Services, educate, nurture, inspire, reaching back with a hand up. Let's get into it. All right, so here is my fabulous return guest, like I've promised my audience, Keisha Wilson. Here she is. Hi, Keisha. How are you? Good morning.
I'm good, thank you. Thank you again for having me back. And hello again, audience. Nice to be back again.
Absolutely, absolutely. So my fabulous guest is returning out from New York State. Where are you exactly again, my friend?
I am in Brooklyn, New York, until I decide to relocate, but no, I'm joking. I've been here for a long time. So hello, everyone from Brooklyn. We are hot this week,
That's
scorching
right.
temperatures and trying to stay cool.
Absolutely correct. Yeah, we are two city slickers here. Yeah, I'm just outside of Chicagoland area. So absolutely. The heat is sizzling for the next couple of weeks. I know I'm very grateful because I think every Labor Day it turns a corner and the weather gets a little bit cooler. So we have a very short summer during the traditional months, but then it does heat up to an Indian summer in like October, November. Things get crazy, but yeah,
That's so funny.
it's
Yeah, but
so
I don't
funny.
mind. I'm like
I
the
don't mind.
heat any
Yeah,
day. No,
yeah,
I'd rather heat than shoveling snow from New York any day. I'm
exactly.
okay.
Absolutely right. Well, those days are pretty much gone, right? You and I grew up in a time where there was like 7 feet of snow. Our parents were shoveling constantly, right? The snowfall has definitely been a lot less. But by the way, speaking of hot, scorching weather, your face looks fantastic. Like you've been out on a little vacation somewhere. Um, yeah,
Thank
that,
you.
that tan looks good. Tan looks good.
Thank you. I know I wish I need a vacation, but I've just been walking a lot in New York. I've been trying to be mindful and do better with myself and health and take
Good.
care of myself.
Yeah.
So I've been walking twice a day in the morning. I try to go early before the sun hits, but sometimes it's out at 6 a.m. And then I try to go again in the evening, before I teach. So this is a New York City tan, but it looks like I went
I
somewhere
love
like the
it.
Bahamas,
That's
so I'll take
fine.
it.
Yes. No, it looks fantastic. Absolutely. Yeah. And I
Thank
definitely
you.
have been walking as well, but I put a hat on. So I definitely still don't look like I've received any color. And I
Hmm.
wish I could take that vacation that I was planning at the end of August, but I just don't think it's going to happen. Just
I
need to keep on working. But that is life.
same. I'm
That is
looking
how it
forward.
goes. Yep.
Yeah.
Yep.
But
But
I'm wearing the
anyway,
SPF. So
yes,
everyone
and we wear
remember
the
to put on
SPF 50. Please wear the 50. Yeah,
yes.
because that
I
really is
have
what
50
makes the
and above,
difference. Yeah, yeah.
100%.
Anything less is just, going to cause a lot of sun damage. So yeah, and
Exactly.
July is the month of UV awareness. So just a great thing that we are talking on and on about vacations and sunshine, but there is a purpose.
Exactly.
July is UV awareness month. So everybody does need to be mindful and increase their SPF levels and wear a hat and long sleeves if you need to, especially if you are fairer skinned. It's just a good idea. So you just don't want to burn.
Exactly.
Yeah.
No,
Yeah, for
or you're
sure.
going through some type of radiation or treatment, you
Yeah.
definitely need to stay covered.
Covered up. That's absolutely right. Yeah. Yeah. But anyway, it's so good to have you back, my friend. And, I really wanted to bring you on today, for your expertise. I know you've been around the the industry around the healthcare niche that we are a part of in terms of compliance, auditing, coding, et cetera. And you've been talking a lot about telehealth services, but I wanted to bring you on specifically onto my podcast today for another area of expertise that I want to be the first one to highlight you for. And that is evaluation and management services. Because the industry has had a massive shift since 2021. I know my audience is well aware of that. I've been talking to them about guidelines and coding changes and definition changes, et cetera, for quite a few months, if not a couple of years since 2021. But I wanted to showcase a real expert here on the show. And so I really wanted you to talk to the audience about, what are your biggest, accolades for this new overhaul that took effect? Or is it something that you actually do prefer the old ways, that we had, the construct of 1995 and or the construct of 1997 guidelines? So I'd really like to get your insights and your preferences on evaluation and management.
So I'm so excited to talk about evaluation management. I love telehealth, but evaluation and management was like my first love. From when I decided to go into coding, when we did that whole section in evaluation management, you know how the curriculum is set up, they always save it for last. So I always say, oh, they saved the best for last. Because it's not the easiest to grasp. But once we did it, I was like, I love this section. Like, I want to do more. What do I have to do as a career to get into do this all the time? And I researched it and realized it was going into auditing, but you needed a few years experience before you do so. So I went into coding, I had multi-specialty, I learned everything, but within that multi-specialty, we were already doing evaluation management for different areas, outpatient, emergency department, inpatient. So by the time I went over to compliance as an auditor, I was already well versed in evaluation management and the tool and the E&M tool. So by then we were using 95 and 97, like you said, everyone's favorite, right? But I just loved compliance. So my CPMA was, I think, my third certification at the time. And that's been my favorite. And you're looking at different audits, whether it's coming from payers or whether you're teaching it to physicians or teaching it to students, as I do. I just love the whole concept of it. And then we had the overhaul in 2021. And like I was telling Sonal, the organization I was working for at the time, it was a hospital setting to teaching physician, multi-specialty, right? And you're in compliance, so you're doing a lot of audits. I probably did to date in that particular organization about 75 different evaluation management sessions. Because think about it, you have different multi-specialties. You're dealing with physicians. They're not all on the same schedule. Right. Sometimes you have to present 6 o'clock in the morning before they go into surgery. But that allowed me to just be able to tailor education, the E&M, the 2021, and teaching it. I love what they did with the update in 2023 because now everyone's on the same page. So I will say some hiccups that we had in 2021 in teaching it was those physicians that were still in the outpatient setting, but also doing rounds in the inpatient setting and seeing patients there. Yes. So you had to teach them 2021, get them to understand, digest it, but then still tell them, oh, but if you're doing inpatient, if you're a specialty, you still got to follow the 95 and 97. So that was so confusing for them. And I felt so bad. I mean, for them, for the coders, I mean, for us too, because we still had to switch hats when we're auditing, but we were more used to it. So they were so confused. So I think this final update that they had in 2023, where now we're all on the same page, was like gold. I was like, yes, finally we can, sunset those 95 and 97 for now, and everyone's on the same page. But I love the new change. I feel like it helps get the provider's thought process a little more. We always say if it's not documented, it's not done, but getting them comfortable but getting their thought process from inside of their head and rolling it out onto paper and
Mhm.
just really telling us the story. I always say you're telling us the story from beginning to end, from the chief complaint of why the patient's there, the history and or exam, and then the medical decision making. So, this is always my favorite, and I try to explain it in such a manner that makes it easy for them to understand and grasp, um, and then implement it. I love that they can either do medical decision making or time, and then getting everyone used to, yes, it says history and or exam. I don't know. You'll let me know what you think or what you saw, but I know initially, physicians, they're busy. They read stuff, everyone interprets it different. And at first, I think they were like, oh, yeah, we don't really need to put a history or exam. Like there were some things that were just not there. And you had to go back. And this is why re-education was so important and be like, no, no, let me clarify. It's history and or exam and what's related to or pertinent to your specialty. So you remember gone were the days when they had to reach all those points in the
Oh,
history or ROS,
mhm.
and looking to get a comprehensive and they're checking areas that may
Yeah,
not necessarily be in their area, right?
that's
Dermatology,
right.
checking the heart and palpitations, they may not need to, but they're doing
Mhm.
it. So now it's perfect where it's depending on what you're seeing the patient for today. And I think that is amazing and what I love. So really clarifying those gray areas is what we continue to do, I think, from the new implementation from 2021 till now.
Yeah, I love it, Keisha. Um, yeah, you're a big fan, I can tell. Very passionate, as am I. And, you made a lot of salient points there. Absolutely. The amount of education we had to do because of the misunderstanding, right? Because the overhaul was massive. So I definitely understand and had many a physician and provider misunderstand those points you just made at the end, which technically is the beginning of a physician or provider note, right? That history and exam. I had many a case where those were just gone from the
Oh,
note. They didn't exist. They were just like,
disappear.
yay, we don't have to do a physical. Yay, we don't have to have a history.
Yes.
Right. And so it
And you
was
turn your
rather
notes like
funny.
upside down. Like
Yeah.
where's this where's the note?
Where's the note? Right. It's like we, the auditors, we the compliance people, then were left confused. Like, why is the patient here? What is actually pertinent and relevant? There's so much detail that was just gone because, again, of that misunderstanding of the definitions and information that were changed in our CPT books, right?
Yeah.
So that's a great point. But in today's landscape, flash forward to July 2024, I don't see that. Now I see a history that is relevant. I see an exam that is relevant. I do, however, um, am in the middle of a audit right now where the education I will have to go back and provide once I'm completed, and the report is written, the EMR needs to be fixed, right? Because that EMR is outdated. They still include the language of 30 system review of systems. I'm like, what? You're not doing a 30 system review for what purpose? For this little problem
Right.
that the patient is there for, right? I'm not going to give specifics, but it is unnecessary to do a 30 system point of review based on these new guidelines. So,
Hmm.
yeah, there's a multi-factor education stuff that has to happen, right? Not only with the physicians and providers and the coding teams, but also help the EMR people, eliminate certain drop downs, certain check boxes, and just do away with it because then you're still pigeonholing our providers and practitioners into the old way, right? You're
Yes.
still making that note unnecessarily voluminous for something like your example of a dermatology patient who's coming in for one simple skin lesion that is suspicious. The dermatologist has no need to go through the entire body,
Yeah. Yeah.
nephrology, cardiology, like all of these body systems don't need to be addressed. Right? So yeah,
Exactly.
exactly. But great points in terms of, I too agree that both sets of our providers, the outpatient folks as well as the inpatient folks and the ER folks, we're all able to finally align in
Yes.
2023. And you're absolutely right. There was confusion during those couple of gap years because those providers in the office space, they do round. They have to go in and round on their very ill patients in the hospital setting. And so, right, I remember talking to quite a few where, okay, so now what do I do?
Exactly.
Right. And they had to be reminded, well, you still have to use the old guidelines for your inpatient rounding and
Yeah.
things like that, So I think there was quite a few years of confusion, and their brains had to go back and forth.
Yeah.
As CPMAs, we're well aware of how to do that. Yes, it's very stressful, but it's a part of our job when we audit, right? Like, so even
Right.
if we're auditing records from pre-2021, we have to use those old guidelines as we're, scoring and evaluating and providing education. But yeah,
100%.
is great points that you made there, in terms of, those 70 plus providers or teams that you had to educate at some point in time, right?
Right.
On all of it, outpatient, inpatient, the emergency
And
department,
specialty, you name
and
it, nephrology, cardiology,
right.
um, ophthalmology, you name it,
Yeah.
it was the different specialties. And it was that organization and plus your consulting as well. So you're also educating other physicians in other organizations or private practice. So you're seeing so much. And I think you as well made a lot of good points. And believe it or not, we're in 2024, but there's still physicians to this date that are still on paper.
Yeah.
And I, see those physicians. I saw them back then in 2021. You educate them, you try to get them on some type of EHR because it is not compliant,
Yeah.
and they may not have been educated in the change. Some of them still don't know that there was changes. So
Right.
they're still, as you're saying, they have those old verbiage. If they're using paper templates, they're
Mhm.
not capturing the necessary information. They didn't know that there was a change. Let's talk about problems being addressed, huh? We're going to get there in a second. So there was so much.
Yeah.
But I think as for us, we're lucky because we get to learn it and then we have to now teach it and
Mhm.
be able to teach it in such a manner where they're doing so compliantly. So I
Yeah.
always say you want to look at the notes and make sure it's compliant. So it was so funny. Besides that organization, it was like 10 different practices, I think, that I've seen a lot within education, but I'm happy for the update and that they're all getting on the same page. And then I also like how you mentioned, yes, if we're doing those audits, those retrospective audits, we have to now use those 95 and 97 if it's before 2021. So as I'm teaching students, whether it's for CPC or CPMA, I always tell them, but you still want to go and educate yourself on the 95 and 97. Because if you end up in compliance or you end up in an area where you're doing those audits, you don't want to be caught off guard and lost and
Yeah.
you don't know where to begin. So it's always good. And then they can better appreciate where we're at now because some of them are complaining, like, oh, this audit. So I'm like, this is like Christmas
Yeah,
when this is
exactly. That's
completely
right.
different from what we
Yeah.
had to deal with before. It's so much easier and straightforward. This is gold. So you want to
This is
appreciate
gold.
it.
Mhm.
Hmm.
Absolutely. Yeah, this is gold. Gone are those bean counting days that you were alluding
Yes.
to, right? They had, oh my goodness, the way the old guidelines were constructed was
Yeah.
just too much, right? Which is what led to that unnecessary, right, documentation and unnecessary review of the whole body for something that is not relevant today in today's encounter for that patient. So, yeah, a lot of great improvements, in my opinion, have been made. And I agree with you in terms of, helping our providers you know, walk through their day, right? It's very easy for them. They are so brilliant in their recollection of what they did for Jane Smith on July 1st, right? They can walk you through the entire day to help support how that claim was billed out, but it wasn't documented, right? So that's the type of education that we can easily provide them once we hear it. So that's why I still do prefer those dictated notes when they're actually just talking into that microphone and it records it. And that's literally them talking through their day, and it's captured, you know. So much nicer than the way so many of the EMR systems are constructed, you know. And also, as a side note, as a patient, right? As a patient, I really don't like when my providers look away from me and they're typing on their little iPad, their little tablet thing, you know, and they're not dealing with me. I'm like, here I am. Why don't you deal with me and do your notes later? Right? Like, why are you simultaneously typing? Yeah.
Exactly. And I think I was telling, I think maybe with some students yesterday, how I started initially in social work, right?
Yeah.
So when I was doing my internships, you're trained where you need to be present. You shouldn't be taking notes when you're listening to the client. And so I was trained in active listening. And then once they finish, be able to go back and repeat everything that was done.
Yes.
And that was something we had to do in the course, right? And you had to submit the tape. So now the professor going to listen to the tape and then look at what you wrote to make sure. And so I think it's the same thing with providers. We want to know that they're really hearing us and that you're not there sitting there typing. And so now we know they get credit for that type, you know, in the medical records, because we know they spend a lot of time reviewing records and different stuff like that. I also think the point that you made, updating, working with IT. So different organizations, I've worked with them with IT. There's no I in team, right?
Right.
You have to be a team, like compliance, coding, IT, all be on the same page, because IT may not understand the importance of the changes, why these elements need to be updated in the record. Some of them, right, still have that 50% of counseling and coordination of care. We still see that regarding time. And so, like you said, they want to update it. So working, you understand it as a specialist. Now getting them on the same page so that the template is now compliant and it makes sense and it flows and it's not stressing the providers out and having them need to fill in unnecessary elements. So I think that's a great thing. That's one thing I love. And I know, you know, people I've worked with in the past always like, oh, we're so thankful for the help that you gave in updating these templates, because we didn't understand the elements of the E&M. So they're not understanding, why do we really have to change these things? You know, does it really matter? So I think all that's important out in building out, you know, these compliant notes going forward too.
Yeah, that's exactly correct. Exactly correct. And kudos to you for being a person involved, you know, with the EMR companies, with the IT people, right? Because you're absolutely right. If you don't have someone as that person to go back to the IT, to the EMR, how will they know, right? That it is, you know, a big part of, you know, that particular product of theirs that needs to be tweaked. It doesn't have to be overhauled. It just needs to be tweaked to satisfy what's going on currently, right? Because they've been, you know, getting away with, that's in quotes, I don't mean that, but they've been getting away with everything since 1995 and 1997, right? So they haven't been forced to make a change, right? So I think that's a great point.
This was a course.
Yeah.
Yes.
Exactly.
And
So
we
I think
know that when we looked at the overhaul, and you know, if you attended those AMA symposiums and they had the panel with the discussion, and it's the different physicians that talked about why they made this change. They wanted to see it more of a thought process. Those that audited before, we saw a lot of note bloat. No matter what specialty you look, it was like a lot of copy and paste. And it's like, it wasn't really for that particular date of service. So you're
That's
like,
right.
okay, well, tell me what happened today. And so this was supposed to help us. So I think, you know, that was super duper helpful. And I
Yeah,
like the panel and when they discussed this, and it's physicians telling us
exactly.
why they themselves were what they were seeing and why the change was so needed. So I think that's important, and I think the note has come a long way. I don't think that we're done though. I
Yeah,
think we're still providing education. I think being proactive. So that's why you have people like us, like working with IT and different organizations to update templates. Not necessarily when we look at or have a routine yearly audit and then you find it and then nothing happens. If
right.
you consistently see a pattern, then you want to work with your compliance department, you want to work with IT and make sure you're updating these. You don't want to continue to have these
Right.
providers document, and it's not compliant.
Absolutely. That's a great pro tip is when education is provided, those changes should happen immediately, right? And if it requires cross department changes, that needs to happen quickly rather than waiting for the next round in your audit cycle, right? The next quarter, the
Exactly.
next year. No, no. We always recommend, as compliance folks, definitely once those deficiencies have been identified, you have to rectify it, right? Take it to the appropriate team. Like, for example, if it happens to be IT, you need
Yeah.
to make sure that that gets taken care of at the same time. That's a great point.
Exactly.
And we always recommend document when you
Yeah.
received your education from your consultant, from your auditor, from your compliance professional, whoever. Document on July 1st, I received my education. I spoke with them for 2 hours. I received the education. I've escalated things to IT. I've escalated things to the coding team. So everyone is now aware of these
Mhm.
changes that have to be made. Yeah,
Exactly. And I think that's
that's a
so
great
important.
point. Yeah, so
I
important.
think that's a great point. No matter if you're coding, if you're billing, I always say get someone's name, get the time, get when you did it. So you leave a paper trail so they know. And then you can go back and look to see when you noticed it and then how are they doing going forward after education. I think that's always important.
Exactly right. Right. It's your medical record, right? It's a good thing to leave that paper trail, that evidence, of when you received the education, what steps
Yeah.
you've taken after that education to rectify those couple of things that were
Exactly.
identified as a deficiency, right?
Exactly.
Because in general, the work you and I do consistently on a day-to-day basis is tweaking, right? It's information that just needs to be tweaked because we know our doctors and providers are brilliant in patient care. It's simply a matter of improving documentation to help support those CPT and HCPCS codes that are going out on claims, right?
Yeah.
As well as those diagnosis codes that are going out in claims. We have to make sure everything is symbiotic, right? Everything
Yeah.
has to make sense to the payer when they review things. Yeah, so yeah, these are
Exactly.
great nuggets, Keisha. Great nuggets of
Oh yes,
information.
I'm like in my glee. Yes, I love telehealth, and I was telling Sonal, like, yes, these E&Ms, these evaluation management codes, they can be done via telehealth too, but that's another subject. But in teaching physicians and students, the E&M tool, like, they're so, or the whole process now, I love it. It's so much to talk about when you're in that evaluation management section. I guess that's why they leave it for last.
Yeah,
I always say, and I know you've mentioned it before, really understanding those definitions is going to help you, right? We're always starting off with, some people forget when you look at notes. I'm like, where's the chief complaint? Like, what's the reason that the patient's here for today? You want to let me know. So when we're looking at a
mhm.
note, there's a few things we're looking at when we're auditing. We're looking for the date of service, right? First things first, let's make sure it's the correct date of service. Second thing I'm assessing before I even start is there a signature to this note?
Exactly
Um,
what I do. Yep.
Exactly. If the note is not signed, then we have some issues right away. And then we start assessing the note. From the chief complaint, we're looking at the history and or exam and medical decision making. But what is the problem being addressed today? I love how the AMA breaks down like what is the problem and then a problem being addressed, the date of service. I think it was a huge thing, and you let me know your thoughts. I've heard you mention it before too, with the problems that's being addressed today. So just stating that a patient's condition is being managed by another provider is not enough to give credit to say that they're managing that problem.
That's right.
So when I'm educating physicians, I always say, yes, we know the patients that come in, they may have a lot of comorbidities and chronic conditions. You want to show your thought process, right? So if it's someone that's coming in for cardiology, they also have diabetes, you're assessing their blood work. There's medication interaction. You want to show your thought process because you are thinking about it. So you want documentation to say maybe the A1C is a little elevated. So you're a little concerned about increasing a certain cardiology medication. So you pick up the phone and call the endocrinologist. You have a discussion about it. You talk to the patient, you provide education, you tell them, okay, follow up with the endocrinology. But your documentation shows exactly what you did. You assessed the labs, you had that conversation with that healthcare provider outside of your specialty. And so when certain things are documented, it's just clear for us to see and give credit and then see the thought process that was done. So I think understanding those problems, we got to start with that column first before we're
Mhm.
talking about what was the problems addressed today and is it clearly identified. So sometimes I'm like, even if it's risk adjustment and you're using MEET, right,
Mhm.
monitor, evaluate, assess, and treat, to me I was like, this is like the new medical decision making. Like, it's
Exactly.
to me, thought, everything is
Yep.
about the thought process and really seeing it unfold.
Yep.
So I always start with that and explain it, like, please, if you just say, hey, follow up with endocrinology, like, we can't count it as a problem. Like, it doesn't show what you did. And even if you did it, it's not there in the paper.
That's right. No, that's so valid. Every point that you made about the importance of problems addressed. I agree with you completely that that particular change was one of the most important changes in the overhaul. It definitely makes the provider, they already think more critically, but it implores them to document the problem addressed, right? You can definitely make notes that they have other comorbidities, et cetera. But if you're not actually addressing or evaluating or managing or treating any of those issues, that's not technically considered that problem to be addressed. So I agree with you. And that's why all of that new green text that is in our CPT coding books is really mandatory for coding professionals to read and reread to understand the fine nuances that happen in that green text, right? Because that green text means it's brand new. And
Yeah.
so
That's why
we never had, that's why you were green. That's why I have a green necklace on. Yep. Green is the theme today. Yeah.
yeah.
But that is why I think coding professionals need to really dig in to those, 25 or so pages of new material in CPT codebook, right? Because we weren't privileged to any of those definitions in years past. This
So
literally
we
happened in 2021. We were just going with what we thought was problems
mhm.
addressed, what we thought was, the data, what we thought was the risk, right? Based on the very limited information provided to us in those 1995 guidelines and 1997, and the limited information we had in CPT from years ago. So, yeah, I agree with you. Um, the physicians, the team at the AMA, all of those folks did an amazing job in terms of helping spell out, all three of the columns that we use to provide a score, a level to those evaluation and management codes, right? So, yeah, I think
Exactly.
it's
And I love what you
incredibly
said.
helpful. All
Mm-hmm.
three,
And like what
right?
you said, all three columns. Because sometimes, I don't know, before, you're doing audits in different areas, different organizations, and you see things and you're like, wait a minute, they only use one column. And it's three, right? But you're choosing two out of the three, whichever meet or exceed, but not just one. So you don't just get to one area and then that's it. You
Right.
want to look to see if anything else was done. So, I think it's so important in clarifying, and as you mentioned and we talked about before, the definitions, like understanding what's an acute
Mhm.
uncomplicated versus acute complicated.
Yeah.
What is, we know it drives everyone crazy, what is a stable condition
Hmm.
versus an exacerbated condition, right? If they have to change medication, if patients not at their treatment plan, like this is not stable.
Right.
It's an exacerbated condition. So you want to look at all the areas, you want to understand the definitions so that you're not confused with the problems addressed and where to start off in that column. Now, that data column, that's our other favorite that we know kind of stress people out a little bit about when to give credit if they order a test and when they review. But I think the update is so clear
Yeah.
as well. Like you're ordering, you're reviewing today, this is the credit for the order and review. So if they come back next week, you can't give credit again for that review because it was
That's
already
right.
done. And then I love the clarification that they have regarding reoccurring tests that may be done on a basis. So I always say you want to look at it. Like you said, look at the green. You're
Hmm.
never going to know everything by heart, as I always say, but you want to get familiar with it because you're like, oh, wait, I read this somewhere, and you know where to go to find the
Yeah.
information. You
That's
always want to make sure it's the most updated one because, like I tell everyone, remember October 1st, the diagnosis code change.
mhm.
January 1st, we had the changes in the CPT. So you want to make sure to see what was changed from last year to make sure you're following the most current guideline for the data service,
Yeah.
right? Be careful
Yeah.
with the data service because if
That's
you're doing a retrospective audit, you want to go back to that TPT book to see what the guideline was that year.
yeah.
And then I don't know, my other pet peeve. You'll let me know what you think. So the risk, when we're talking about morbidity and when it comes to surgeries and stuff, like what is the risk to the patient? So
Yes.
I always say with that section, there's so much we could talk about with E&M. We're gonna have to come back for a part two,
You
but
will.
that section, um, regarding surgery, like what is the risk and benefits for the patients? Like I've
Mhm.
seen a lot of templated, oh, risk and benefits was discussed. But what is the risk and benefit when it comes to that patient? If
Mhm.
they're going for a gastric bypass, but they have other complications and they tend to bleed out and different stuff, that should be addressed in the note. So you're telling me what are the complications to this patient? Maybe if they do this surgery, they may bleed because they're on anticoagulants and different stuff like that should be clear. And then just that staple template is not enough. It's not
Right.
sufficient.
Right.
Yes, you can give credit, if it wasn't, but tell us the thought process because you really do go into detail with these patients
Mhm.
about the risk and benefits. Like, I'm not just gonna come in and have a surgery and you're like, okay, yes, we're gonna do it. You're telling me what's the risk for a person my age and maybe if I have other stuff going on. So I see that's one thing that I constantly see that's lacking. And I always educate in that part, that one, and then services that are performed separately.
Mhm.
You want to be careful, especially if you're doing it on time, that you're making notation that these services does not include this time. Because I think at first, in the beginning, I've seen like across the board, people didn't have statements and other services were done. So you're like, okay, is this included in time or not? And so something that's what, we had to go clarify. So these are my, you know, other things
Yeah.
that I'm looking out for when I'm looking at these notes as well.
Exactly. No, your pet peeves are specific to what you've been auditing in your universe, your physician population, right? So I hear you loud and clear. Um, as auditors, we have so many points that we have to review, right? There's so many things to analyze in a medical record, whether you are, doing evaluation and management strictly as the office or inpatient service, or in conjunction with a minor surgical procedure, or you're doing a major surgery, and your thought process comes in. If you're doing a post-operative evaluation, right, we have to consider notes that we've seen that fall within that global period. What do we do there? So there are so many notes that we've seen. I agree with you that, need that improvement, right? Painting the medical picture clearly, based on, like you were stating, the condition of the problem. We've had so many conversations with our providers on what is stable, what is unstable, what is acute. Because we've had these new definitions, they haven't provided many examples, however, right? And so it's up to the compliance and education folks out there to help providers, with specific examples that could support in their specific patient population what could actually qualify, But in general, the basics are pretty common. When the patient is coming in pain, they are not at goal. They are unstable, right? They are coming in with a complaint. It's kind of a rare day when the patient just walks in and they're fine. They just want you to give them a thumbs up, right? That's kind of rare. So most of us go in because we have a health concern. We're in crisis for some body part or the other, right? So yeah, we are coming in unstable. We have something that's not at goal. But yeah, there's, many, many other occasions that I need to bring you back on, because I really do think we can talk about the entire problems addressed column, one entire session. The data, I still see problems with that column. I don't see it done correctly, right? So there's much more education that we need to continue providing to make sure that they get the full credit that they deserve. If they just use those simple words like, I reviewed an external film, right? But I've seen so many records that key word is not there. So I can't give you that moderate level of data because I don't know that this film is coming from somewhere else. You didn't give me that word of external or the name of the facility that the films came from. There's so many ways to analyze, how those few sentences in the note could be tweaked so we can provide you with that additional support. And then, of course, risk to patient management is huge for the surgical space, like you had stated. And I've seen an amazing surgeon provide me with their thought process, and it's amazing. And I wish I could just, clone those notes and send them around the country and be like, just use this. This is so good. Please, if you have severe patients like this guy did, use his note. Like, it's amazing, because we want that full linear thought process, of why they had to talk to this patient for so long, why they had to give them 5 different surgical options, and then wait for the patient to come back with the authority that he's considered it after a month. And okay, now I'm going to pick, surgery number 3 because it's the safest, whatever, right? So yeah, I agree with you that there's much more that needs to be done in terms of education. I don't think we're out of the woods. I don't think our providers are out of the woods yet, especially because this new overhaul of evaluation and management guidelines are under targeted probe and educate audits by the CMS. That's happening this year. And now we know why. I hope the audience understands why, because, even though Keisha and I are very happy and we dance for joy with the new overhaul, there's still a lot of misunderstanding in the provider community that is going on. And of course, the audit from the CMS is happening right in 2021, dates of service. So of course, right when everything just turned on Of course, we're going to
Exactly.
see some additional tweaks and deficiencies identified. But our providers received a lot of grace periods, so I expected this
Yeah.
audit to be happening, but it's unfortunate, right? Because
Yeah. I
it
figured it was
is,
coming down the pipeline. It's like, okay, when? Because
yeah,
you knew it was coming. You knew it was. You kept telling and educating physicians and organizations like it's gonna come. They're watching
it's going to come.
because you get paid.
Hmm.
Doesn't mean that it was done correctly.
That's right.
But you also want to take these target pro and educate as an opportunity of education to do it
Mhm.
right, and then implement process and procedures and going forward to make sure it's correct. It's interesting. Some people, they may not be so keen on education, but education is needed, right? That's one of like the 7 elements of the whole compliance plan is
Yes.
like training and education. And I think it's so important because there's so much changes. Like for us to stay on top of it. I mean, before the guidelines came out, and then like what, a week or 2 weeks later, like the proposed final rule came
Correct.
out, and we're like, oh
It
gosh,
was
now
two
there's
weeks later.
2000. Like literally for us to read is like we're constantly learning, but it's to
Yeah.
really help. I mean, it's keeping us busy, right? And we get to do what we love.
Yeah.
But there's so much to learn with the evaluation and management, and some people just like it's like look at the book and the guidelines and that's it, but you have to think bigger and add it to your
Yes.
specialty and really understand it and implement it and get them to understand why it's important. And as you said, we can talk about each section. We didn't even talk about total time yet. And
No,
that's a whole new thing.
that's right.
And I always say you want to start, especially like if I could give one tip before we go, it's you're starting off in the book. There's so many categories and subcategories when it comes to evaluation and management.
Yeah.
You want to start off by, where's the place of service? That's going to help you select the
Ah,
appropriate one,
ah,
right? So make sure it's appropriate service so you're in the right column. And then if it's new and established patient, understanding when it's a new patient, were they seen in the last 3 years? Did they see someone within the same specialty or subspecialty? People forget about those
that's right.
subspecialty. Credentialing in your organization is important. So how are they credentialed? That's another thing. And then understanding like initial versus subsequent in the inpatient. I think that will help so many people, especially new coders when they're trying to find the category. They have to assess these things. And then once you find the right category, now we can assess that evaluation management section and if it's a problem or, critical care or other stuff. Oh, so much fun stuff.
I know. Yes.
A gift that you just unwrap. I always say gives the answers. There's everything in the book we need to know. I
That's
mean, it
right.
starts off, right? We have to look at payer policies. That's completely different. But it's just becoming one with your book and getting so familiar and looking at exercises there, listening to webinars, podcasts that talk about it, that break it down. Because sometimes one person explains it one way, a second one, but then the third, you're like, aha, a light
Yes.
bulb goes off. And that's why we're here.
That's right, Keisha. Brilliantly said. Absolutely spot on. My goodness, absolutely. The amount of variance in our education professionals, you couldn't have said that better, right? You teach your way, I teach my way, the third person teaches a different way, right? And it's just a matter of, what the student
Yeah.
is comfortable with, right?
Mm.
Like, where is that education being received well? Which one of the three, That's so well said because the amount of education that is required to master the E&M from 2021 and 2023 moving into the current times, right, is necessary.
Yes.
We understand that our professionals who are providers understand patient care swimmingly, right? So it's a matter of them finding the right partner to team up with for the business side of
Yeah.
things, right? So that person and their team can help handle and keep abreast with all of the changes
Yes.
that folks like you and I are well aware of. Like you stated, those diagnosis codes change each and every year on October 1st, but we're provided those new codes and or those new guidelines much earlier to
Yeah.
help prepare the physician and his or her teams much earlier. right? For that October 1st change. And like you stated, the CPT codes change each and every year on January 1. But we're prepared earlier, when we receive information from the AMA, generally in the fall.
Yes.
So there's just many, many people out there who do this type of work. And they do it really, really well because they're passionate about the particular CPT codes or HCPCS codes or ICD-10 codes or auditing, like you and I love, or compliance overall. So it's just a matter of, partnering up with the right person or people to help make sure that you maintain proactive compliance, because that is the most important thing. You do not want to be caught in the crosshairs of a post-payment audit by any payer, whether it's commercial or government, because
once they find something,
they can nitpick and then extrapolate. And that is never a pretty look when they blow it out of shape, when it was just one deficiency that we identified on an internal audit. We can quickly clean it up for you, quickly. We're not going to extrapolate it to this insane amount like the payer does. We can make it shiny and clean pretty quickly. But again, that's a proactive approach that education professionals take, not on the back end. But yeah, Keisha, you provided the audience today with so many incredible insights. It's remarkable. And I'm really, really happy that I've showcased you for evaluation and management, because I really do think it's important that people know that this is one of your favorite things. It's one of your strengths, right? Because you've been doing it since 2021, providing multiple physicians and hospitals and entities education for all of these years.
And even before then, with the 95 and 97, but that overhaul just propelled us when it comes to these new changes. So it's like we eat, sleep, and dream evaluation management, right? That's what made me want to go into auditing and compliance in the first place, that whole section in the course.
No, it's my favorite course as well. The CPMA was my very favorite thing. And, I can't even recall why I wanted to get the CPMA other than I thought I want to be an auditor. I love auditing my surgeons at the time. I loved my surgeons and I loved their documentation style. And this was years ago. But the CPMA is my very favorite credential. I love it.
That's one like I hold near and dear. Love risk adjustment too, but I loved, because you're auditing as well in compliance. So it's diagnosis is them, but that's
the whole thing.
Taking it and breaking it down in such a way.
Exactly, Keisha. Well, I'm so happy that you were on with me today. Let me just provide the audience with my links that I have for you for your LinkedIn.
Come find me. Come talk to me.
Come find Keisha. Connect with Keisha. She's incredible. And I'm going to provide all of these details in my show notes as well. And there's her business page on LinkedIn. And then here is her actual company itself. So please reach out to Keisha, find her, request her services, get some education from her, whatever. She does a little bit of everything. So, it's incredible to reach out and find her. And she's fun, as we've heard in today's conversation. She's fun. She's funny. She's fantastic. She's fantastic. And hopefully I can bring you back on again, because I think we really should spend time and dive deeper into each of these columns, because I think our audience can gain a lot of insights from you. So,
definitely. I'm looking forward to it. Thank you so much for having me again.
Oh, absolutely. It's my pleasure.
I'm going to be dreaming about E&Ms for the rest of the day. And it's funny, I'm teaching it tonight for my course. we're in the E&M section. So
It's meant to be.
yes.
All right, Keisha, thank you so much. I'll see you soon, okay?
All right. Thank you, Sonal. Have a good rest of the weekend.
Thank you. You too. Bye.